Hi, everybody. This is Dr. Wajiha Javed. I'm the head of public health and research at Getz Pharma, and I welcome you to our today's episode. Today, we have Dr. Saad Omer with us joining from the US. Hi, good morning, Dr. Saad. How are you?
I'm doing well.
Okay. So, Dr. Saad, let me just give you a very brief introduction about him and what we're going to talk about. So, Dr. Saad is the inaugural director, as well as the director at the moment, of Yale Institute of Global Health. He's a professor of medicine at Yale School of Medicine, and he's also a professor of epidemiology of microbial diseases at Yale School of Public Health. He's worked across continents. He's serving right now as the advisor for the vaccination rollout plan in the US. He's written for numerous medical journals, including the NEJM, JAMA, Lancet, British Medical Journal, Pediatric Journal, American Journal of Public Health, and the Nature. He also has been awarded the Morris Hillman Award by the National Foundation of Infectious Diseases on his work around the impact of maternal influenza immunization on respiratory illness in infants younger than the age of 6 months. Dr. Saad serves on various advisory committees. He's working with the US National Vaccine Committee. He's on the Presidential Advisory Council on Combating Antimicrobial Resistance. Dr. Saad is a vaccinologist and an infectious disease epidemiologist. And I thank you today for joining us on a voluntarily basis to impart some knowledge and to answer some questions around myths and misconceptions around COVID-19 vaccines. So today, our audience would be joining from around various countries. We do have a lot of myths and misconceptions now that we have piling in results from phase 3 of various vaccinations. The media really isn't playing a good role. They are coming out with a lot of myths that need to be addressed. So Dr. Saad, first of all, would you like to tell us that as of today, the 4th of Feb, how many vaccines have received approval around the world?
So it depends on the country specific. In the US, it's only 2 vaccines that have received authorization. But if you look at, across countries, there are 5-6 products that have received various level of authorization.
Mm-hmm. And have there been any that have been dropped out?
Well, after authorization, no. It's it's a natural state of things in terms of vaccine development, that when you start your trials, there are a lot of vaccines candidates. Some do not make it to even phase 3 trials. Some are not, the phase 3 trial is not successful in terms of showing efficacy, etc. So that has been there as part of a usual process that we are seeing. But having 5-6 frontline vaccines is a good portfolio for the world to have. Even if 1 or 2 countries have, like each country has separate vaccines authorized for various reasons.
So, Dr. Saad, can you quickly walk us through the different type of vaccines and what, according to your experience, because you've been working since years as a vaccinologist, which one would have the most safest profile and the highest immunogenicity? You can perhaps do a comparative analysis around the 7 ones that have been approved around the world.
So, I think the head-to-head comparison has not been done. So it hasn't been done in a single trial. So each population where trials are done is different. And so that dictates for example, the force of infection, the stage in the outbreak. For example, the same vaccine evaluated in the summer in the same place has a different force of infection going around because of the intensity of the virus compared to intensity of the outbreak compared to fall, autumn, or or winter. So it is not appropriate at this point because these to compare the efficacy directly. However, I will tell you that there is heterogeneity in the case definitions that were used for phase 3 trials, and the circumstances in which the trials were conducted. And so keeping that in mind, there is some variability in efficacy. But one thing that is interesting is there is less variability in protection against severe disease. So there's more consistency in terms of severe disease, such as hospitalization, etc., various vaccines.
Hmm. So, Dr. Saad, the question that we get asked a lot is that if you've had COVID-19, you still need to be vaccinated afterwards.
Yeah, so the country recommendations vary according,
Mm-hmm.
but some of the countries, but we do the current recommendation suggests that you should be vaccinated. Uh,
Mm-hmm.
but some countries allow, and so the WHO definition language is also somewhat permissive to wait
Mm-hmm.
for up to 90 days, for example, a few months if,
Mm-hmm.
after infection,
Mm-hmm.
after you're out of it. During active disease, it is recommended that you wait until that's over so that you don't mix up the symptoms of the disease with any reactogenicity, etc. But after you have recovered, you should get vaccinated, but you can wait according to certain country recommendations for 2 3 months, but not beyond that.
Not beyond that, because after that, there are no neutralizing antibodies, hopefully.
Well, no, we don't
Mhm.
know at this point, but the
Okay.
evidence that you are protected is stronger for the first 3 months. Remember, it's a year-long outbreak, and so it's some of these long-term protection studies. So now data are suggestive data are there for even 6 months protection after natural infection. But
Mm-hmm.
what proportion is protected, or what some of the nuances are, that needs to be worked out. But we do know that it is, according to some data at least, that you can wait for a few months, 2 3 months,
Mm-hmm.
within the safe zone.
Mm-hmm. So there has been, so I was just reading the New York Times today, and there has been a plan of, I mean, a debate around whether if the second dose of vaccine can be delayed so that there can be more volumes to supply around the world.
Yeah.
So instead of giving a booster dose to one individual, wouldn't it be better if, more individuals can receive the same amount of vaccines? So what do you feel about that?
So there is a genuine discussion going on even between experts uh,
Mm-hmm.
on this. Having said
Mm-hmm.
that, this is where most advisory committees have landed. Uh,
Mm-hmm.
where most of the recommendations have landed. And then
Mm-hmm.
I'll describe the reasons beyond that as well. Uh,
Sure.
One thing is, for example, the data. So there is that came from observation that after
Mm-hmm.
between one dose and second dose, or those who never received the second dose, the
Mm-hmm.
efficacy, but primarily between first and second dose during the trial, the first dose efficacy seemed to be pretty high. Uh,
Mm-hmm.
so that was reassuring.
That
Uh,
was very true. Yeah.
but in terms of the gap between those, uh, advisory committees go by what the data are available in terms
Mm-hmm.
of efficacy data.
Mm-hmm.
The WHO, for example, allows, so the ideal interval is 3 to 4 weeks between the two mRNA vaccines.
Mm-hmm.
Uh, but they allow for a gap up to 6 weeks or something,
Mm-hmm.
6 7 weeks around that time. And the idea is that that's where the data were in the trial, etc. So some people got
Mm-hmm.
delayed vaccination. So that was the perception. That was the recommendation. Right now, the suggestion again is, the recommendation is to have, for those that were evaluated for 2 doses, was to do 2 dose schedule, because there is, for several reasons. First of all, you haven't
Mm-hmm.
done a sort of a randomized trial for that, but
Mm-hmm.
also the new variants that are emerging, that want you to be to err on the safer side of efficacy. And remember, it's not just the number of doses that are a bottleneck. Our distribution system is also a bottleneck. Uh,
Yes, true, true.
so 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 therefore, focusing on a pain point on one side doesn't necessarily mean all your pain points will resolve. The second thing
Mm-hmm.
is that the interval may vary.
Mm-hmm.
Yesterday or 2 days ago, data came out from the AstraZeneca Oxford vaccine,
Mm-hmm.
um, that suggested that, from that vaccine perspective, the suggestion was that the vaccine interval is okay up to even 12 weeks. So it may vary by vaccine type as well. In
Mm-hmm.
fact, the efficacy seemed to improve up until at least 12 weeks of gap, and there is biological plausibility for that. That sometimes having a little bit of a gap is actually more conducive to a booster response. But that is vaccine by vaccine right now. That's the state of evidence. It may evolve as observational studies come out, where people will inevitably receive the vaccine with different gaps, etc. So there may be more data, and recommendations may evolve between 1 to 2 dose vaccination. But right now, those are the recommendations that mainstream advisory committees that have looked into the data in detail have come up with.
Got it. So another question while you were talking, came to mind. What are your opinion on alternate vaccines? So if you receive component one of a different kind of vaccine, and then you mix and match it with another category of vaccine, like AstraZeneca and Sputnik, we are doing. So what are your thoughts around that?
So in Sputnik, it's already two different.
Adeno 6 and Adeno 5.
Yeah, exactly. So that is that's the same vaccine. Like it is the same schedule, and so the overall the regimen is evaluated. But what you are talking about is mixing, let's say, AstraZeneca vaccine with the Pfizer vaccine where it's available, or Sinopharm versus AstraZeneca vaccine. So in those kinds of situations, currently the evidence is not there to say that you can do that between doses. However, this is again emerging state of evidence, based on the biological plausibility and the information and the understanding we have of how these vaccines work. Advisory committees have suggested, both in the UK and the US, slightly different but overlapping language, that suggests that if in a situation where you have, for example, vaccinated with one vaccine, when you get to their second vaccine dose, you don't have the same vaccine available, you can give the other vaccine. It's better to give the other vaccine rather than let them
not giving it at all.
Not giving it at all. So that's the language that is there in terms of that. It's not a willy-nilly, mix and match situation, but it is permissible in situations where the trade-off is between not giving the vaccine, not giving the second dose, versus just and giving a different product from another company, etc.
Subcategory. Got it. Okay.
But all of this will change. So there are studies planned and are likely to happen that will evaluate them head to head in that kind of situations, kind of swapping schedules, etc.
Got it. So we'll have to wait for that. We can't answer that at the moment. Yeah. Another question that's coming to mind is that Novavax and J&J just released their results last week. And there has been a lot of debate around serious adverse effects, around efficacy, and now Novavax being a candidate that requires a very lower temperature. It's got a very good safety profile. They tested it on the UK strain as well as the South African strain. How do you see the world vaccine dynamics change after this announcement?
So both Novavax and J&J vaccine news is very welcoming. So it is very welcome news, and here's the reason why. The more tools we have in our toolbox, the more precise, the more options we have for each country, and that contributes to vaccine equity. And we have more options in case epidemiological circumstances change, there are new variants, etc. It's good to have more tools in your toolbox. But also, that bodes well for the total vaccine supply. So I'm sure you're aware that sort of not all manufacturing is, there are overlaps in the manufacturing and filling and distribution process, but then there are distinct steps based on the technology you're using. So the more technologies you have that have been shown to be promising, J&J is a vectored vaccine. Novavax is an antibiotic vaccine. It's a protein-based vaccine, and so these kinds of things will give us the ability, us meaning the world, the ability to expand production using redundant production processes, etc. So that helps us, cushions any future blows in terms of one vaccine sort of manufacturing facing any problems and bottlenecks. So that expands that. So that's a good news. That's a very good news. And with J&J, since it's already evaluated as a single dose vaccine, that gives you more options and going farther, etc. And the better, the more favorable vaccine storage characteristics also are helpful, because that you can reach out. Like, you cannot maintain ultra cold chain that is, for example, required for mRNA vaccines from all around the world. But for especially for hard to reach places and so on and so forth. But if vaccines that allow you to allow themselves to be refrigerated can reach further and further.
Exactly. Okay. Yeah. So another question that is coming to mind is about supply chain and distribution.
Yeah.
And that is whether, so let's quickly just talk a little bit about developing countries and whether you feel that even if vaccines do reach either through COVAX or through, direct government funding to developing countries, are they right now at a stage where we can accept this? Are our systems capable enough to even vaccinate, quarter of the world's population within a year's time or not?
Not yet. And but it doesn't mean it's not doable. And it takes political will. It takes a massive mobilization of logistics. It takes smart planning. So this is not amateur hour. People have planned mass vaccination campaigns before in all sorts of locations, including low and middle income countries. It is time to leverage that kind of experience. We must recognize that this is a campaign of unprecedented complexity, because throughout the world we vaccinate children. We don't vaccinate adults, and when we vaccinate children as in birth cohorts, meaning only the children who are born this year will be vaccinated, or when they get older for the doses. We do it in annual cohorts. We don't go out and vaccinate the whole adult population or majority of the adult population. So number of doses that are required, the logistical complexity that is required is unprecedented. But that doesn't mean, as I said, it's undoable. Low and middle income countries have been having SIAs, supplementary immunization activities, for example. It's not the same thing. You can't go out and vaccinate on bus stations and that kind of stuff with this vaccine because of the cold chain requirement. But the thing is, the planning, the muscle memory of planning complex, large-scale, national level campaigns is there, and I think that should be leveraged. One thing we need to consider is when we look back, as countries, as the whole world, we should be able to be able to look back and be proud of the response that we were able to reach the most vulnerable as well as the most privileged. It will be a tragedy if we don't do that, and it doesn't happen because our health systems throughout the world are inherently unequal. They favor the privileged. They favor those who have money and resources and access and connections. And it would be a huge tragedy if that inequity in baseline health systems is further exacerbated in vaccine delivery. But so you have to make efforts in terms of where the access is ensured, which communities are engaged, and so on.
Okay, which brings me to the next question. Could you just briefly highlight what Covid-19 Fund is for developing countries, and what are the efforts being made by different donors, just so that everybody's on the same page? Our audience would like to know that.
So COVAX is an entity that was created by Gavi, which was formerly called the Global Alliance for Vaccine and Immunization. Now they call Gavi the Vaccine Alliance. The World Health Organization, i.e. WHO, CEPI, which is a coalition for pandemic innovations, and so these kinds of entities and some private entities as well came together very early on and said that, look, in order to develop vaccines that are suitable for especially low-income countries, but for the whole world, what we are going to do is we're going to invest in certain candidates. And for example, AstraZeneca, Novavax, etc., are part of that list. And then make them available to everyone. So there would be countries that fully pay, so high-income countries, for example, but also low-income countries that are self-paying or through other funding, can can get access to these vaccines. And the target is to at least have enough vaccine for 20% of the world's population. So this was initially underfunded, but there's more and more resources are available. But it's a very complex entity. And so countries are doing their individual needs, not just high-income countries, but low-income countries as well. But the problem is that if you don't go through that mechanism, if the world, for example, the number of commitments Canada has of number of doses is higher than its population. So those kinds of things block supply and create inequities between countries. So it is in our interests globally to have a healthy vaccine program that across various countries, not for just one or two countries.
True. But the COVID-19 fund, I believe, would only be mobilizing vaccines by Q2 or Q3.
Yes, so that's the thing. So the next few months, they will be mobilizing vaccines, etc. And I think that in any substantial quantities, there may be some vaccines available before that. I would say in the next few months. That's the forecast.
Okay. It brings me to my next question on vulnerable populations and how different countries are looking into them. What are the kind of strategies that have been adopted? Are there particular vulnerable subgroups of the population that you feel, from your experience as a vaccinologist and an epidemiologist, should be done first?
So I have the privilege of being part of the WHO working group on WHO SAGE working group on COVID-19 vaccines. As one of the initial efforts out of that group were two documents. First of all, we came up with a values framework. So what would be the values and ethics framework countries should use? So that as they make their own decisions. The second documentation was the prioritization roadmap, saying within countries, how should they prioritize? And so there were the different factors that were taken into account, including the stage of supply. So the first 10%, 10 to 20%, and then 20 to 50% supply compared to the world's each country's population. And their epidemiological situation. So we said that countries that have a widespread epidemic are different in terms of their needs compared to that have localized epidemics versus countries like New Zealand who don't have a current epidemic. So focusing on, in the interest of time, just the ones that have a widespread epidemic, which is most of the world, most of the countries, but not certainly all of the countries. The recommendation was to have a public health strategy that squarely focuses on mortality reduction early on. So the idea is, and health system preservation. And so that is also indirectly reduces your mortality and severe morbidity. Because the other choice would have been is to interrupt transmission. But the problem with an transmission interruption strategy would have been that you need a certain threshold of coverage, vaccination coverage, to have to make any dent in transmission itself. The idea is to go sort of head on and reduce mortality, reduce death. And there were several reasons. First of all, there's consensus on reducing death. The other thing is death is irreversible. So you can, other consequences, economic consequences, come back. You can bounce back from, at least theoretically, although it's hard. But you can't bring people back from death, unless you're in a horror movie. So in that kind of a situation, the groups that were recommended to be prioritized in phase 1 were healthcare workers, but not all healthcare workers. Healthcare workers at highest risk of exposure to SARS-CoV-1. So, for example, those in ICUs, those in emergency, etc., with this high exposure scenario. And
high exposure for COVID-19.
And then the other group in phase 1 were older individuals. And it was stated that then older individuals will be, the cutoff will be decided by each country. And so that was for the first 10% supply. That was the recommendation. For 10 to 20%, there were other groups like primary school teachers, because child development is more irreversible. People with comorbid conditions that put them significantly higher risk, etc. A few other groups, and then 20 to 30 to 50% was another group. So that was the approach that was recommended. And like all WHO-based recommendations, the idea is that these are guidances for country to adapt and adopt for their own situations, and it has been adopted and adopted, with some variation, but across the board, overall, that framework has held, especially for phase 1, which countries are focusing on, is the elderly and healthcare workers.
I guess it is commonly, this is how every country is looking into it. So another question, let's talk about the elderly. We have data piling in on Astra, on Sputnik, on Sinopharm, and they're showing variable levels in the elderly population. Even between Moderna and Pfizer, there have been reports that certain states have, stopped the campaign just because of side effects happening in the elderly. Could you just briefly do a comparative analysis, especially for those who are above the age of 60, and the safety profiling within that?
So the safety data is fairly reassuring. So the differences in terms of mainstream country policies, I'm not talking about rumor in the media. Safety, the country policies are based on, the safety data are fairly good across these vaccines where these data are available. Even for Pfizer and Moderna, it is fairly robust safety data. Increasingly now, approximately over 20 million people have been vaccinated, even in just the US, and then let alone other countries, etc. And the safety data are available. But here's the nuance there. There is some unnuanced reporting going on. So if you have the highest risk, so the survival rates in high-income countries are very high in terms of people get to be 70, 80, 90.
Yeah.
But when they are 70, 80, 90 in nursing homes, etc., people are often close to their, they are in palliative care situations, and they're close to the end of life. So there is baseline high mortality rate in nursing homes, in very elderly people who are 85, 90, etc. So if you are going to vaccinate them, there will be a baseline rate. Some people. So that's what some of the reports that you are referring to, that's not safety signal, because it has been looked at. It has been looked at by looking at the comparison of, and the predefined causality criteria. So what would be a causal event? So in terms of safety, it is similar across the mainstream vaccines that have been approved by most countries, by various countries. Is that in certain countries the trials were done in age groups with different cutoffs, or in certain situations earlier on there was a cutoff and then they expanded to more older people. And therefore, the efficacy data are variable by some vaccines. And so advisory committees have taken a slightly different perspective on based on this uncertainty in terms of based on the variability of availability of data. Some have said that, look, we have other options that can go in the elderly, so why not choose the other product? For example, Germany did that for the AstraZeneca vaccine. They said, essentially they have other options. They have the Pfizer option, etc., and mRNA vaccine options. So why don't we go with that in the context of that option for the elderly? Why not do the other vaccine, the AstraZeneca Oxford vaccine, for those under 55 or 65? 65, I think, was Germany. France is under 55. But that wasn't based on safety data. That was because those trials did not recruit them. Some other places, like the UK, has said, look, okay, even if we don't have efficacy data from phase 1 trial, we have immunogenicity data, so the biological response data, that indicates that these vaccines will have similar efficacy in the elderly. So that's the judgment call groups have made, but it wasn't a safety-based judgment call that advisory committees made or countries made.
Fair enough. So that does answer the question in the elderly population. Now, coming on to another group, we don't have a lot of data around pregnant women.
Yeah.
and them getting vaccinated. So what are the overall global protocols for that?
So there is sort of the WHO language was first clarified in terms of the recommendations that were there for a couple of vaccines that WHO has had recommendations around, and even at country level. Basically, so there are two considerations. First of all, we actually do know that the ICU admission rates, hospitalization rates, etc., are twice as high, approximately twice as high in pregnant women if they get SARS-CoV-2 compared to non-pregnant women. So it does produce a higher level of risk for them if they get vaccinated, if they get the infection, not vaccinated. So in that context, the consensus, emerging consensus is that they should be offered the vaccine, but the decision making should be based on their circumstances. So they should not be. The idea is, for example, if you're a pregnant nurse, you should be offered the vaccine, but then you work with your healthcare provider, where possible, based on the risk-benefit situation. Like, what is your exposure? What's happening in the community? What stage of pregnancy it is, and so on and so forth. So based on the risk-benefit situation, and you contextualize that decision. But it hasn't been that you don't vaccinate against this, according to most sort of mainstream advice. So that's the nuance. So that's how the uncertainty is being handled.
Right. Another segment of the population that we don't have results on is children under the age of 18.
Yeah.
Now, with the new strains coming in, and talks about this paper from London School of Tropical Medicine came out saying that the UK variant was more transmissible in children. So, are there any talks among global experts around vaccinating children for COVID-19?
Yeah. So we will not achieve herd immunity unless you vaccinate children. They come in the numerator and the denominator. So we will not achieve really high, especially in low-income countries, low and middle-income countries, where the populations are on average younger. You won't interrupt transmission. You can still reduce a lot of deaths and mortality by directly protecting high-risk populations. But if you want to interrupt transmission, you'll have to have children included in that. So therefore, there are now trials being conducted for some of the initial vaccines that were approved in children. And the way these trials are conducted often is you go already for the Pfizer vaccine, they did trials from 16 onwards. So that was authorized in the US for 16 onwards. Some countries have done 18 onwards, but there is some flexibility for the Pfizer vaccine. For children, other children, the trials are now going down by 1 or 2 year chunks. So from 18 to 16, 16 to 14, 14 to 12, etc. So that's how these trials are usually conducted in chunks of age. And those trials have happened. I personally think those trials should have started earlier, even earlier, because we need to get a viable option for children and do it the proper way, after doing trials.
Okay. Another question, again, I'm just reading them off the screen, is the immunocompromised population. Any guidelines around that? These are a few vulnerable groups that I really wanted you to talk about.
Yeah, so I would suggest people go to the WHO SAGE guidelines. And in there, when we drafted that, so usually, again, it's based on risk-benefit, but generally it's a permissive recommendation for immunocompromised populations, including specific groups such as HIV populations, etc. as well. So the vaccines for which the recommendations are available, that's the current focus. Obviously, it is vaccine by vaccine recommendation. Right now, the WHO recommendations are mainly for the Pfizer and the Moderna one. Then the AstraZeneca one is likely to come out soon, and then within the next few weeks, it is likely that there will be Sinopharm and Sputnik 5 vaccine recommendation may come out, and so that's wherever there's a recommendation, the recommendation is to give them the vaccine, looking at individual risk benefit, but make it available.
Got it. Okay, now let's talk about delivery systems. We just have the last 10 minutes, and I want to focus a little bit on vaccine delivery. How do you think most countries should roll out their vaccination campaigns? Should it be door to door? Should it be buy out of pocket? And so, what are the various pros and cons of different levels of vaccine rollouts?
I don't think that it should be buy out of pocket at this point. It may become when the supply is available, enough supply is available. It would be so. There could be hybrid systems where those who can pay, but it should be the option for the most of the population should be zero out of pocket costs. The reason is that the viruses are impacting underprivileged communities more. But because of that, everyone is impacted. So it's everyone's interest that the most vulnerable communities get that vaccine. If you are sitting in a large home and you are able to social distance, and your only hindrance is that you can't go out and socialize, or main hindrance is that, and you're able to work, from home, versus someone who has to go out in streets and earn a living for their family and their kids. In order to make sure it's equitable access, that you should also get it based on your risk factor, and they should also get it based on their risk factors rather than the ability to pay, is more equitable, but also more smart, because that's where the mortality is happening. And so if you reduce mortality, you reduce vulnerability, then everyone can open up more quickly. So that's one thing. So there should be a transparent process for making this vaccine available. Governments should obviously encourage a fair market so that there is incentive to produce and supply the vaccine. So it's not that the supply of vaccine is sustained and it is supported through sort of internal or external funding. Even in the U.S., the vaccine development was heavily subsidized by the government, etc. So these kinds of things should be there so that the robust market for supplying this kind of stuff, the more you support it, the more robust it is. But in terms of individuals, out-of-pocket costs should be minimal, if not zero. And so that should be the approach. But also making sure that the process is transparent. The process is easy for the most underprivileged to get, and so on and so forth. So that should be the approach. Once the supply is stabilized, once the highest risk groups are vaccinated, then you can switch to a more, both private and public vaccine distribution, just like what happens in the private vaccine market.
Got it. So do you see this happening on a yearly basis? So just suppose, let's talk about what is going to happen in the next couple of years. Do you see COVID vaccine given to us on a yearly basis like influenza? Do you see it as part of the EPI programs like polio, for instance, in developing countries or in countries where it's an endemic? What do you foresee?
So we don't know at this point, but we do know what will inform this decision. We don't have exact information on this in the sense that there's scientific uncertainty there. But it is likely, based on what we understand about the biology of vaccines, it is, and the fact that this is such a high, overall, that these are highly efficacious vaccines, it is likely that the immune response for the antigens against which people, against which people are vaccinated, will go on for at least a few years. The big uncertainty are the variants, and that depend on how quickly we vaccinate the world. So it's a benefit. One benefit of vaccinating everyone is then that you have the probability of variants emerging, and so that will depend on the speed of these variants emerging. But if they do emerge in a way that you have to have sort of repeat vaccination or annual vaccination, that's not the end of the world either. Because then in a lot of countries annual influenza vaccines happen, and so that's a doable thing. The key is to get out of this current emergent scenario through vaccination, have a ton of supply so that people can vaccinate it quickly and equitably, and then we will have a better idea in the next few months whether how frequent repeat vaccination is needed, or whether repeat vaccination is needed in the first place. So because often, even if a vaccine is 90% effective or 95% effective, especially against severe disease, the risk benefit would be that, you remember, for all of these, as I said, that this efficacy that we talk about, the top line efficacy is mostly lab confirmed, or specifically PCR confirmed symptomatic disease of any severity. But if you look at only severe disease, the efficacy seems to be even much higher. So if you get in a situation where the efficacy against severe disease or field effectiveness is pretty high, but it drops down just a bit with variants, but still high enough, then in that kind of a situation, you may not need a repeat vaccination on an annual basis, or you may need repeat vaccination for a smaller group of people. So there are options. So what I'm saying is that it's not a done deal that even in the presence of new variants, you will have a repeat vaccination scenario. There is emerging evidence, emerging data that will tell us where we go, but those things, the picture will become clear in 5-6 months.
Fair enough. Fair enough. Okay, so just one last question before we wrap up. Do you see disruptions in the world's vaccine supply? If we are to achieve herd immunity, if we are to put an end to this emergency situation, let's compare it with our ability to produce vaccines, to send them off, have a good maintained supply chain. Where do you see this whole balance ending, and how?
No, so there are inherent uncertainties in any vaccine supply scenario,
Yes.
because as you know that manufacturers follow good manufacturing practices. There are a lot of things, for example, ultra cold chain. You need refrigeration capacity. You need specialized glass to tolerate those temperatures, etc. That supply and all of that stuff. Specialized fridges and all of that stuff is needed for So, but the more steps you have, the more likelihood, the higher the likelihood that you can develop pain points during that whole process. On the positive side, the advantage of having redundant or multiple technologies is that if one type of manufacturing has a pause for some reason, other stuff is still there and can perhaps even take over in the medium term, etc. So again, it is, while the disruption in supply remains a concern that we should pay attention to, it's more and more one is reassured that even if there is a disruption, it will not be a total disruption of supply. Things that will not come to a complete halt.
With so many trials that are just finishing up phase 3, sorry, this is one last question, then we'll wrap it up. With so many trials that are finishing up phase 3 and so many that are awaited phase 2, I mean, that would be completed maybe in the next 6 months to the end of this year. What do you forecast 2022 to look like?
I think 2022 will be better than 2021. We don't know how better, but I think we will have, several countries will achieve drastic reduction in mortality. Because one of the reasons, if they deploy the vaccines in a smart, equitable manner, because I'll give you an example. Of the US, 80% of the deaths happen in approximately 16% of the population. So if you cover that 16% directly with a laser-like focus on reduction in mortality, even if there is transmission going on, you can reduce the consequences of the infection. And so you can then you can build towards transmission interruption and more sustainable control of this disease. So therefore there are signs for hope, but we'll have to be smart and equitable in vaccine deployment.
So it has to be a very well thought out approach. So Dr. Saad, thank you so much for your time. Any last minute suggestions, change? I just want you to talk a little bit about vaccine hesitancy, if you can. You've done work around that. Just in a couple of lines, and then no more questions.
Yeah, no. So I think vaccine hesitancy. It's not in this case. There is an additional group of people. There's some people who are going to refuse vaccine no matter what.
Nevertheless,
but that's a very small group of people. In this case, people had initial questions because it's a pandemic, it's a new vaccine, and things were developed with good speed for good reason. And so that group is, our research has shown, is movable. In a sense, it's a persuadable group. And the way, and the good thing is that the process that has been followed for the vaccines that are authorized has been mainstream, etc. And we have been pushing for sharing of data, or publishing data quickly for several vaccines. For example, if you take example of Pakistan, AstraZeneca data are available in peer-reviewed literature. The data from Sputnik 5 is now available in peer-reviewed literature, and detailed data from their phase 3 data. We hope that the Sinopharm data will also be shared, not just in press releases, but also in peer-reviewed literature, where you can look at the details of stuff. But certainly Moderna and Pfizer, etc., those data are available openly. So what it does is that it reassures that the science behind these recommendations are solid, and so therefore there is cause for being reassured about it. So far, the safety profile has been very good. Even for anaphylaxis, etc., that there were reports. It is true, but that's a manageable risk. And countries have successfully, as I said, in the US now, more than 20 million people have been vaccinated and you can mitigate that risk by screening by history of allergies to that specific component. But that risk hasn't been seen in other vaccines. For example, it has been anaphylactic reaction risks hasn't been seen in the any substantial risk hasn't been seen with the AstraZeneca vaccine, the Sputnik 5 vaccine, and ostensibly with the Sinopharm vaccine as well. But although one would want to see detailed data from the Sinopharm vaccine.
Yes. Pakistan just got its first shot of Sinopharm yesterday when inoculations were rolled. Pakistan, as in started inoculations as of yesterday. And people above the age of 60 at the moment have been advised not to, because we don't have enough data available talking about the safety profile in that particular age group.
So I would say it's not the safety. I would say that it's reasonable different advisory groups and different countries are making their judgment. But we should also keep in mind the 60 in Pakistan is 80 in other countries. Yes. So the number of people, unfortunately, that survive beyond 60 is similar to that survive beyond 70 in other countries. So the number of people that are covered, hopefully there will be, that's why it's important to do these studies and trials in the population which is targeted. And hopefully Pakistan will, even if it's below 60, it would prioritize between 50 and 60, for example. So the group that is at high risk, and hopefully the data will become available there. And as I said, countries like Germany and France, etc., when they looked at the data, they looked at the data from a perspective of phase 3 efficacy data. Not safety. Safety was not part of that equation.
Got it. We haven't had any head-to-head trials in the world anywhere.
Head-to-head, so that's unusual. So usually, even for other vaccines, companies do not do head-to-head trials. And because for various reasons. One of them is that, again, once you have done that, the ethical justification of doing large phase 3 level, so there may be justification of doing immunogenicity-based trials, but the correlate of protection identified, which hopefully we will get soon. But it is usual for them not to do head-to-head comparisons. Usually, when advisory committees that make these recommendations look at the data, they look at the whole picture in terms of what impact is on the overall supply, etc. Not just, but also looking at what is the impact. Are there real functional, practical differences between impact on severe disease? And so that practical that comes into consideration when an advisory committee makes policy.
Fair enough. So, Dr. Saad, I think we're over time. We were supposed to be 45 minutes. Is there any last minute message that you want to give? And then we'll just sign off.
No, this is good. I am of the optimistic side. We will get through this together as a world. We should stay the course in terms of non-pharmaceutical interventions until we get enough people vaccinated, and then there will be a new normal, but we will come back to normal. I know you're going into multiple countries, but if I may, I'll say I'll recite an Urdu verse by Faiz Ahmad Faiz with your permission. माना कि ये सुनसान घड़ी सख्त घड़ी है, लेकिन ये भी फकत एक ही घड़ी है, हिम्मत करो जीने के लिए एक उम्र पड़ी है. So there is
light at the end of the tunnel.
Yeah, there's light at the end of the tunnel, and this too shall pass.
Thank you, Dr. Saad, for your time. Thank you very, very much. Very much appreciated.
All right.
We'll just wrap it up now. Thank you.
Bye.
Okay. Bye-bye.